This
everybody.
conference will now be recorded.
We are going to start our first webinar for the ACRM Pediatric Rehabilitation Networking Group. Thank you for joining us today. We will be recording today's presentation so that it will be able to be saved and played at your convenience and to share with others after the presentation is over. So I'd like to thank you for joining us today. As I said, we're here for the first Playtime Pediatric Rehabilitation webinar series for the Pediatric Rehabilitation Networking Group. And just a few opening slides before we get into the content of today's presentation and just some rules and business. During the presentation, we ask that you mute your microphone or mute your phone just so there's no background noise as the presentation is occurring. You can, if you have questions at the very bottom, you can put them in your chat box and then I will read them at the end of the presentation so that our attendees, our presenters can answer your questions as they come in. As a reminder, we'd love to have you join us at the annual convention coming up in November 5th through 8th in Chicago of this year. We have a wonderful lineup of pediatric content that will last the entire time, so that we will be at no shortage for pediatric topics, and we really hope that you will join us for that. This is our Pediatric Rehabilitation Networking Group contact information. You can find us on the ACRM homepage. We invite you to come on and join our group, see what we do. Our next meeting is going to be Thursday, September 12th at 4 p.m. Eastern Standard Time. And there is a link here that you can use to join the meeting if you'd just like to hear what we do when we're going through our regular business meeting. Also, you can connect with us and ACRM through social media, including Twitter, Instagram, Facebook, LinkedIn, and Google+. And you can find us at all of the networking groups at ACRM. For example, on Twitter, we are ACRM Pediatrics. Please check that out. And really what we strive to do in the Pediatric Rehabilitation Networking Group is to be the interprofessional rehab organization with our central theme is that no child should feel their disability and that we work together to make sure we address their needs. Okay, so to introduce today's webinar, our topic is Acute Flaccid Myelitis, AFM, Clinical Considerations and Outcome Descriptions. We have an interdisciplinary team with us today to talk about our content, joining us from Kennedy Krieger. I'm going to introduce our speakers and then I will turn over presenting controls to them to go through. And as I said, feel free to add your questions to the chat box as we go and we will take them at the end, making sure to mute yourself during the presentation period. So joining us today is Dr. Cristina Sadowsky. She is, along with me, Angela Chicha, the co-chair for the Pediatric Rehabilitation Networking Group at ACRM. She is also the clinical director of the International Center for Spinal Cord Injury at Kennedy Krieger Institute in Baltimore, a program caring for both children and adults with spinal cord-related paralysis, and built on the philosophy that functional restoration is activity-dependent and can be best achieved through structured medico-rehabilitative interventions. She is board certified in physical medicine and rehabilitation and spinal cord injury medicine. Dr. Sadowsky's research interests center on prevention of complications in children and adults with paralysis related to traumatic and non-traumatic spinal cord dysfunction and the efficacy of activity-based restorative therapies in helping individuals with long-term paralysis recover sensation, movement, and independence. She has published in highly regarded specialty-related peer-reviewed journals, wrote chapters in seminal specialty books, has organized numerous courses and seminars, and has been invited to lecture in different universities and at national and international meetings. She is the co-chair of the Pediatric Rehabilitation Networking Group of ACRM and the co-chair of the Education Committee at the American Spinal Cord Injury Association, and thoroughly enjoys mentoring individuals passionate for the care of individuals with disabilities. Our second presenter today is Kaitlin Hagen. She is an occupational therapist and the manager of therapy services at the International Center for Spinal Cord Injury at Kennedy Krieger in Baltimore, Maryland. She received her Bachelor's of Science and Bachelor of Health Sciences in 2009 and her Master's of Occupational Therapy in 2010 from St. Francis University in Loretto, Pennsylvania. She completed the Pediatric Certificate Program through Drexel's University Department of Physical Therapy and Rehabilitation Sciences in 2015. She has presented internationally on activity-based rehabilitation principles and their application in pediatrics. She has participated in the Acute Flaccid Myelitis Rehabilitation Group nationally and has treated both inpatients and outpatients with AFM. Her clinical interests are pediatric and adult spinal cord injury, rare neurological disorders, functional electrical stimulation, and aquatic therapy. Our third presenter today is Courtney Porter. She is a physical therapist at Kennedy Krieger International Center for Spinal Cord Injury. She obtained her doctorate of physical therapy from the University of the Sciences in Philadelphia in 2012. Her primary interests are in pediatric applications of ABRT, aquatic therapy, and respiratory training. She received her certificate in aquatic physical therapy clinical competence in 2017. And our final presenter today is Janet Dean, who attended the University of Michigan, completing her bachelor's degree in nursing and a master's degree in parent-child nursing. She is board certified pediatric nurse practitioner and is also a certified rehabilitation registered nurse. As a nurse practitioner for the International Center for Spinal Cord Injury at Kennedy Krieger Institute, she specializes in the prevention and treatment consequences of both traumatic and non-traumatic pediatric spinal cord injury. She has a particular focus on transverse myelitis and acute flaccid myelitis. She serves on the scientific advisory board of the Transverse Myelitis Association and attends their annual Quality of Life Family Summer Camp for families and with children whose lives are touched by transverse myelitis, acute flaccid myelitis, or other rare neuroimmunologic conditions. She has over 30 years of experience in the specialty of pediatric rehabilitation. We have such a fantastic group of presenters today, and I am now going to turn controls over to Dr. Sadowsky to get us started with the presentation.
Thank you, Dr. Chicha. Actually, the order is a little bit different. Janet Dean is going to start. So can you see the slides?
Yes, we are able to see your slides. If you want to go ahead and put them in presenter view, that's great.
Hi there, this is Janet Dean, and I'm going to start out. I just wanted to start out giving a little bit of a historical perspective on AFM. If I can get this to move forward. Oh. Just I got to get oriented here. Okay.
Keep on going.
There we go. Okay. So I'm going to give a little historical perspective on acute flaccid myelitis. And, you know, as we know, historically, the most devastating virally associated acute flaccid paralysis was poliovirus, which is a member of the Picornaviridae family and an enterovirus. And in the 1950s, there were over 15,000 new cases of poliomyelitis per year in the United States alone. With the introduction of the inactivated and the oral polio vaccine in the 50s and 60s, the cases of polio in the developed world just plummeted. And by 1979, polio was considered eradicated in the United States, and national surveillance for flaccid paralysis was discontinued. There has always been sporadic cases of non-polio flaccid paralysis, continued worldwide. And in 2009, we did a poster presentation on 2 children that we had treated, and their pictures are up there. with predominantly gray matter spinal cord injury and upper extremity flaccid monoplegia. And at that time, we were calling it atypical flaccid myelitis, or some people were calling it a polio-like syndrome. And then in the fall of 2014, there was a nationwide outbreak of enterovirus D68 associated respiratory illness that sent an increased number of children to the ICU for respiratory treatment. And concurrent with this respiratory illness outbreak, Children's Hospital of Colorado and then other children's hospitals in North America reported unusual clusters of children with the initial presentation of respiratory illness, who then went on to develop acute paralysis, and the CDC was alerted. Medical experts were gathered and worked with the CDC to develop a case definition for this neurologic condition, and they settled on the name Acute Flaccid Myelitis for consistency. In the fall of 2015, there were fewer cases, but again, in the fall of 2016, there was an even larger outbreak and a larger number of children diagnosed with acute flaccid myelitis following a respiratory infection. This trend has continued with spikes in AFM during the late summer and fall months, generally between August and October, most prevalent on even years. And as of this morning, when I looked on the CDC website, to date, there have been 574 confirmed cases since the CDC began tracking AFM in August of 2014. AFM has confirmed in 43 of the 50 states. And as of this morning, there's been 13 confirmed cases out of 76 reported cases so far in 2019. Now
I'm just going to ask you, if you could, if everybody listening could please mute yourself, we won't get that back, we won't get that echo.
Whoever joined last. Okay. Nope.
If everybody could just please double check and make sure your phone is muted or your computer is muted.
Let's try again. Whoever joined last, please mute your phone. Okay.
I think no, we're still there. Everybody please double check and make sure you're muted.
Let's try again. It's not going to work if I'm unmuting. Thank you.
I'm going to go ahead and manually mute everybody. So just give me 1 second here to go through and mute all of our participants. I think we've got it. So if we can go ahead with the presentation.
Okay, Janet.
All right, so I'm going to talk a little bit about the characteristics and the standardized case definition. For most children, there's a prodromal, often febrile, respiratory or GI illness in the preceding 5 days before the onset of neurologic symptoms. Most patients report clinical improvement with preceding illness before the return of fever, neck pain, back pain, along with the progression from full strength weakness and flaccid paralysis in one or more extremities that can occur over a few days to a few hours to a few days. The presentation is almost always symmetric with proximal weakness greater than distal weakness and upper extremities generally more affected than lower extremities. The presentation is often accompanied by a stiff neck, headache, pain in the affected limbs, sometimes cranial nerve abnormalities, and there's varied reports of at least initial bowel and bladder dysfunction that generally recovers. Most severely affected children can develop respiratory failure, autonomic dysfunction, including swings in pulse and blood pressure, as well as dysphagia. By definition, the standard case definition, the MRI must show longitudinal lesions involving predominantly the gray matter, generally the anterior horn of the spinal cord, that affects motor function. Children with AFM generally don't demonstrate a clear sensory level or loss of sensation, but may have some initial alterations in sensation. Because some children don't have an MRI completed, you can have, we now have a definition for a probable case, which involves the clinical criteria of acute flaccid paralysis in one or more limbs, as well as demonstrated CSF abnormalities, including white blood cells, and often there's increased protein. So the definition was first created in 2018 or 2014, and the most recent updates have broadened the age. It used to be just kids under 21. Now it's at any age, and they added kind of the word flaccid for more clarity. So causes of AFM most commonly are associated with poliovirus, but there's increasing evidence that enterovirus D68 is the primary suspect. So treatment for AFM, so at this time there's been no randomized controlled clinical trials to guide therapeutic recommendations, so management is generally based on expert opinion. Treatments that have been used include IVIG, high-dose intravenous steroids, plasmapheresis, and antiviral therapy. There's no significant clinical improvement or deterioration noted with any of these therapies. For the most acutely ill kids, mechanical ventilation, treatment of autonomic dysfunction, and nutritional support is needed. Early PT to prevent complications of prolonged PT and OT and speech, prevent early complications of prolonged bed rest, provide progressive mobility, and to improve endurance so kids are ready to come to the rehab unit. Early treatment and aggressive ongoing rehab is generally the only agreed upon treatment. And I just put this slide in to remind myself that the cases that were seen in 2018 were a bit different than the cases that were seen earlier. The average age of kids seen in 2018 was 5 years old. And what was striking about 2018 is the number of kids that were admitted to the ICU. So half of the children were admitted to the ICU, and of those admissions to the ICU, 27% required ventilator support, and 87% required mechanical ventilation. So there was, and upper extremities were affected more than lower extremities, and often bilaterally. So it was a bit different this time. So I'm just going to talk a little bit long-term consequences, and these are part of the reason for early aggressive rehab, not only to facilitate neurologic recovery and maximize functional outcomes, but we're also looking to prevent or minimize long-term consequences. And most of these consequences for many of the children are neuromuscular in nature and include severe muscle atrophy, joint subluxation, joint contracture. We've been seeing very rapidly progressive scoliosis in some of the most severe kids, and also rapid loss of bone density. And limb length equality is yet to come, but I have already been seeing it in kids from 2014 and earlier. That's all mine.
That's all you?
Yeah.
Okay. So patients with acute flaccid myelitis, the presentations varies from monoplegia to tetraplegia. 5% of them make full recovery. 18% make a full recovery within 4 months. We see the other 80% on the rehabilitation. The ones that actually make it to our unit are the rest of the 80%, the ones that are left with significant neuromuscular deficits. Interesting findings. Nearly 100% of our cases in 2018 required pharmacologic intervention for hypertension in the acute phase. There is an increasing numbers of pathologic fractures that are being noted. Sometimes they are occult and they're discovered on admission. Sometimes they're discovered throughout the rehabilitative process. They're not always symptomatic. We have a very low threshold for looking for occult fractures because they're very, very common. In fact, we're going to present some data at the upcoming national conference that's going to look at the number, the frequency of fractures in both upper and lower limbs. I'm just going to make a note about diaphragmatic pacers because traditionally flaccid paralysis does not respond to electrical stimulation, and you're going to see throughout our presentations that it does. On July 15th or 16th, study or case presentation was published documenting the efficacy of an early diaphragmatic pacer implant in a child that was 21 days after the onset of acute flaccid myelitis. She was 4 years old in requiring full respiratory support. We implanted a pacer at week 3. The left diaphragm responded, the right one didn't respond so well. You can see over here that she has some responses, and she has about 3 or 4 more units. In one of the fields of, if you put an electrode into the diaphragm, normally you should see 6 to 8 more units. This child had 4. On the right side, she had nothing. Turns out that about 3 weeks, so at 3 weeks and then at 8 weeks and then 19 weeks, not only that she started breathing spontaneously over the ventilator, she increased her ventilator-free time, well, ventilator-free, paced breathing time from 30 minutes at the day 1 of pacer insert to 8 to 12 hours. In fact, right now, she prefers to stay on her pacers. Again, only one diaphragm responds. She does not have any return of motor function, or it's minimal. She has one finger in extension and another, the other wrist in flexion, so she has minimal return. But she's able to breathe over the ventilator and to augment her breathing with the pacer. If you really look over here, her tidal volumes without the pacer are 100 to 180, and with the pacer, they're doubling to 170 to 230. So this is the first case of early implant. We have 3 others that are later implant. We don't have the data yet for the later implant, but stay tuned. And now for the real reason why you're here.
So this is Courtney from Physical Therapy. We're going to go ahead and get started talking about what sort of rehabilitation you provide to these kids with acute flaccid myelitis. So you have to remember with children who receive an injury early in their life that your therapy is really focused on rehabilitation. These children don't have a previous knowledge of the skill to rely on, and they don't always understand the end goal that you are working towards. But with ABRT, we're able to allow children to practice this novel skill and attain a higher level of health and function. It's also important to remember that very young children have immature brain and spines, which comes to your benefit because you can use that plasticity. Traditionally, young children with spinal cord injuries show better than adult levels of recovery after an injury and also continue to make improvement over many years. So why do we need to do activity? It's well known that regular physical activity throughout the life is important for maintaining a healthy body. That being said, 60% of the global population is failing to achieve the minimum physical activities recommendations. If you add a chronic physical condition on top of that, like these children have, they're at a greater risk for inactivity than the able-bodied peers because they're not able to participate fully with those activities that their peers are doing. So the therapy that we provide here is activity-based restorative therapy. There are 5 key components that I'm going to go through now with a couple additions to that. When it comes to very young children, you can apply ABRT or activity-based restorative therapy to all ages. ABRT is a repeated near normal activity, and you want to remember to go both above and below the level of lesion. This is intended to optimize the neurological system and offset rapid aging, physical deterioration, and the secondary complications that come along with spinal cord injury. It's characterized by a high intensity, task-specific, and pattern activity, and again, both above and below the level of lesion. Some of your key factors, especially when treating children, are creativity is pretty important. You want what you're doing to be very family-centered and focused towards the child and their whole family. And remember that your individualized treatment plan can often evolve and change as the child is growing. They're achieving new milestones, they have new interests, so your plan is going to have to always evolve. The ultimate goal of ABRT should be to increase the child's independence in both mobility and function. So we're going to go into each of those components of activity-based restorative therapy now. The first is functional electrical stimulation. There are 3 types of electrical stimulation that we use in ABRT. The first is neuromuscular electrical stimulation, or NMES. This is electricity applied across the surface of the skin over an intact peripheral nerve, which evokes an action potential and leads to muscle contraction. The second is functional electrical stimulation, or FES. This is the application of electrical stimulation to a paralyzed nerve or muscle to restore or achieve a specific function. You often see this with orthotic substitutions. And the third is transcutaneous electrical nerve stimulation, or TENS. Most research shows TENS used as for pain modulation by exciting the peripheral nerves, and this is via sensory, motor, or noxious stimulation. With activity-based restorative therapy, our sensory settings are typically used to achieve a sensory input to the nervous system. So some benefits of FES are to increase bone mineral density. Your goal is regeneration of the nerves. You can assist in decreasing muscle atrophy and improve blood flow and muscle health. This can improve and maintain muscle mass during or following periods of inactivity. FES can be used in combination with the other components of ABRT. So I just have a few clinical examples of FES. So this picture here is a patient doing the upper extremity FES ergometer. So he has the electrodes on his arms, and then he is cycling with the ergometer, and the electrical stimulation is timed and paired appropriately. And then just some continuation of some clinical applications. The patient in the middle is, again, participating in FES ergometry. She's using the lower extremity bike. The patient on the right is actually also using the lower extremity bike. So he's using the electrodes that are paired with the bike. The bike is cycling without his legs attached because he is too small for that. And then he's doing just some reciprocal patterning kicking activity. We've also added bells to his ankles to increase his motivation and participation in the activity. And then remembering that we are treating children, so trying to make it as fun as possible. So the patient on the left is showing that we just try and engage them in the activity. He was able to color his electrodes. It makes him want to use them a little bit more. We also often call them stickers, and our ESTIM units tickle machines to make them a little bit more child-friendly. When it comes to parameters for electrical stimulation, you'll want to use a low frequency and a long pulse width. This allows time for the slower moving motor units to respond with a greater refractory periods. That being said, as it was mentioned earlier, these patients often have sensation, and those low frequency and long pulse widths can be a little bit more uncomfortable. So it might take time for you to slowly build up to a level that the patient can tolerate. The second component is weight bearing or weight loading. This is loading across a joint while promoting proper joint alignment and muscle co-contraction surrounding the joint. There are multiple benefits of weight bearing, including improved bowel and bladder function, decreased bed sores, increased range of motion, improved autonomic regulation, decreased spasticity, increased bone mineral density, improved cardiovascular function, improved motor function, and improved quality of life. It's important to remember weight bearing through both the upper extremities and the lower extremities. So I have a few examples of each. So the patient on the right here is getting weight bearing through her upper extremities by propping on her forearms while sitting. You can also prop on extended arms and weight bear through the full arm. The patient on the left is doing a quadruped position, which is great for both upper and lower extremity weight bearing. He has assistance from a therapist and an overhead lift for his trunk and lower extremities, and then he's weight bearing through his forearms to make the activity a little bit easier for him. The two patients on the left are just showing some different options for prone weight bearing on forearms. The patient on the top obviously just needs a little bit more support, so he is over a wedge with his forearms propped on the bench, whereas the patient below can do the activity a little bit more independently. And then when it comes to lower extremity weight bearing, you can do activities like tall kneeling and half kneeling, as well as supported standing frames. Supported standing frames have various options that can increase or decrease your level of support. There are also standards that can allow the patient to propel themselves in the stander, as well as standards that have gliding components for reciprocal upper and lower extremity movement. All right, the next component is locomotor training. So locomotor training is an activity-based rehabilitative strategy. It's designed to improve sensory, motor, and autonomic function, along with health and quality of life. It provides sensory cues to retrain the neural patterns that result in effective locomotion, and it emphasizes recovery of motor function using the intrinsic mechanisms of the nervous system rather than a compensatory strategy. Some of the benefits of LT include increased walking speed, independence, and endurance, improved gait symmetry, improved balance, motor recovery, improved gross motor skills, and increased reports of well-being, life satisfaction, and perceived quality of life. There are 4 principles of locomotor training: to maximize weight bearing on the legs, to optimize sensory cues, to optimize kinematics for each motor task, and to maximize recovery and minimize compensation. There are 3 components to LT, which are treadmill training, overground, and community training. This patient here is showing a traditional setup for locomotor training. He has one person helping at his hips to provide hip extension and assist with weight shifting, and then one person at each lower extremity to provide sensory cues and facilitation to optimize kinematics during gait. So I have a short video here just showing someone, oh, we flipped, sorry about that, participating in locomotor training. He actually has a 4th person assisting him because he needed a little bit of help for his head control. So he has the traditional 3 people and then a 4th person providing assistance at his head. With LT, it's important to just remember that you want to minimize compensation and maximize recovery. So you're really looking for near normal or perfect patterning while walking. The next one would be mass practice or patterned activity. This is a repetitive task-specific and non-task-specific activities. You want to promote cortical reorganization. So remembering that in constraint-induced movement therapy, you're achieving a benefit not from constraining the uninvolved side, but from the increased use of the involved side. So using that theory, you want to do repeated activities multiple times over multiple days or hours. Mass practice can show improved strength and range of motion. And remembering that perfect practice makes perfect, so you want these activities to be as near normal as possible when you're doing them. You can also incorporate some other components, including some of the principles of locomotor training and FES. So technology is one of your really good friends when you're trying to achieve higher repetitions, especially with children. So this patient, I don't know why these are all flipping, I apologize, is participating in robotic assisted gait training. So he is getting a lot of steps with the assist of the machine. We are also using FES with him. So he has electrical stimulation paired with this activity to his lower extremities. And then the patient on the right is playing a Wii game while practicing his standing. He also has his left arm in a gravity minimized plane to make the activity a little bit easier for him. You can use other devices like EMG trigger devices, FES trigger devices, or exoskeletons can all be helpful to increase mass practice. And then the last component is task-specific practice. So you want to remember to practice context-specific motor tasks, and you want to train the functional task rather than just training the impairment. You want your activities to be relevant to the patient, that you want them to be random so that they can facilitate retention, transfer, and generalizability. You want to remember that repetition is key to do them as much as possible. And it's often important to break down the task to find the component weakness. And you also want to remember to give timely and positive feedback for these patients. You can also incorporate some of the other components of ABRT along with task-specific practice. So while a patient is brushing their teeth, have them standing at the sink, FES to an ankle dorsiflexion while walking, and then high repetitions of elbow flexion followed by a self-feeding activity. And then it's just very important to not let bad habits persist. So you don't want your compensatory strategies to outweigh the rehabilitation and the normal activities that you're doing with the patient. They're going to figure out on their own how to get things done. Patients will teach themselves tenodesis. They'll teach themselves how to do things with one hand, to finger walk their arm different places, to use their toes or legs to do an activity. So you want to remember that that cortical reorganization is responding to all of that non-use as much as it is to your therapy, and to make sure to do those as near normal or near perfect activities in therapy. So some of the additions that we do with ABRT are vibration can be added to any of your interventions. Vibration is a side alternating repetitive motion, which stimulates a movement pattern that is similar to a gait pattern. This will create a motor and neural learning effects by stimulating an involuntary stretch reflex that can quickly and effectively improve some of the existing residual functions and specific movement patterns. There are different settings that can help with various goals, including muscle tone or recruiting nerves to fire. And then aquatic therapy is another addition to activity-based restorative therapy. You can use all of those principles that we talked about in the aquatic setting. Depending on what property of the water that you're using, you can facilitate weak muscles or provide resistance to stronger muscle groups. Some examples of activity-based restorative therapy and aquatics include locomotor training and partial body weight supported gait training, high repetition of reciprocal patterned movement, standing, sitting, or upper extremity activities in a gravity minimized area.
Okay, so this is Kaitlin. I'm one of the OTs here, so I'm going to kind of take over from here. So we wanted to kind of review some of the secondary complications that we're seeing with acute flaccid myelitis. These kids are developing scoliosis, shoulder subluxations. They're at high risk for fractures. They do have good sensation, but this can also lead to complications such as high anxiety, and it also can put them in some different compromising positions because they can pull themselves out of positions with their distal strength, but then can't return to a good postural position if they're in a wheelchair. So just things to think about as providers working with these kids and really watching this closely, because what we're seeing is like something like scoliosis, for example, is developing very quickly. And so it's important for us to try to use bracing or electrical stimulation and different items such as positioning in the wheelchair to try to prevent that scoliosis from developing, or at least try to slow it down. So just things to think about as you're working with these kids. And you can see here different ways that we can modify positions, such as this little boy on top has his one arm in extension, but the one that is in flexion, supported on his elbow and forearm, is the side that he has a pretty bad sublux on, so it's putting a little bit less pressure through that shoulder, but still allowing weight bearing to align that shoulder. And on the bottom here, you can see we can use Leuco tape or kinesio tape to try to decrease that sublux. Some more examples here is another little boy just finding different ways to use home equipment for families to be able to carry out some of these things at home. So the boppy pillow here is something that can be used at the house and is a good way for a patient to have some support at the trunk to decrease too much weight bearing through the shoulders, especially if they're at risk or have subluxation and need that support, and putting e-stim on the shoulder as well to try to correct that sublux. And here are just some examples of trying to ensure patients have good alignment. So this little girl here, the therapist is giving her good support and tall kneeling to try to correct her hips alignment as well as her scoliosis. But we also want to look at the longer term outside of the therapy time, what kind of bracing and positioning can we do for this child so that she's not in a bad position outside of therapy. And then you can see for the scoliosis picture here that electrical stimulation is being used to try to facilitate a muscle contraction to help strengthen those muscles. And then we would definitely want to look at bracing for this patient outside of therapy. So a home rehab program is very, very important for these kids. It's definitely a lifetime of care that they need, and AFM, especially since they're children when they get it, typically requires us to watch them as they grow and change and as they continue to progress through life, because their goals are going to change as they get older. If you have a kid at 3, their goals are definitely going to change as they enter school age, and then again as they become teenagers and adults. So really making sure that we're providing them with the care they need across the lifespan. But this means that they are going to be going home and having to carry out a home program to continue to maximize recovery, but also just be a kid and enjoy life too. It's really important. So, and the good news is ABRT is activity, and kids like to be active. So if you send them home and get them back into the community and back into school, that can help to get them active and have ABRT happening on a daily basis. So it's really important. Some of the things that we work with families on is getting electrical stimulation units for home, standing frames, whether it's mobile or glider, that's usually ideal so that the child or patient can be moving. A wheelchair if they need it, and bath equipment are kind of the common equipment that we recommend for home. And I just want to throw in, we're talking a lot about PT and OT, but speech therapy is a huge part of our program as well on the inpatient side. These kids have a lot of anxiety with eating and tolerance to food by mouth. So especially if they have a trach, we're seeing that as a big issue, and speech therapy has really taken the lead to try to get them to eat by mouth. Also working on their vocal quality and volume and improving their muscle strength around their mouth. And then assistive technology as they need it to interact with their and meet their daily lifestyle needs. So next, I'm going to get into the fun stuff. Some of the outcomes that we've had using ABRT. We focused on our inpatient rehab for this, and we took about 29 kids who we saw up and through 2018 and reviewed, did a retrospective review of their data so that we could present that today. And just to give you an idea of what the inpatient rehab program is they get PT 2 to 3 hours a day, OT 1 to 2 hours a day, speech therapy for up to an hour a day if they need it. Behavior psychology has had a huge, huge part in working with us on the inpatient unit and outpatient. We've seen they're actually going to be coming out with some data on how anxiety has been much more relevant in the kids with AFM than it is in kids with typical spinal cord injuries that we see on the inpatient unit. So something to keep in mind as well. Neuropsychology as needed. Social work has been very helpful in child life, recreational therapy, respiratory therapy, nursing, and of course the medical team are all part of the inpatient rehab program. So a very interdisciplinary group. And the children that we included in the study came to inpatient acutely, which we defined as within a year of diagnosis. And we had the kids included in this review that we did. We had them on the inpatient unit for more than 2 weeks so that we could really see a change. Most of the kids were admitted for 6 to 12-week admissions that we pulled. And we can get into the outcome measures that we saw next, if they were age appropriate. So the first outcome measure is a homegrown scale, and it is one that we are working on publishing, and it's validated in spinal cord injury, and it's been validated in brain injury. And we actually are seeing some nice changes using this scale with the kids with AFM. The first 10 questions, you can see that it's really based on some of the kids with less movement. You can actually see changes with these first 10 scores because it's really focusing on trunk control and head control and just tolerating being upright, tolerating splints. So you're able to really see changes in those kids with these numbers. And as you look at the next 10 questions, these are higher levels. So some of those kids that we have with more of a monoplegic presentation, that's where we'll really see changes with those kids, because this is more focused on walking and higher level transfers, standing balance, doing stairs, etc. So just wanted to review what the PAMs was before we got into that. So the results here of the SCIM, the PAMs, and the WFIM scores. And you can see here they all had very good changes from admission to discharge, except for the WFIM cognition scores, which we would not anticipate having a big change because cognition is not typically affected with these kids. We did see some changes, and we attribute that to the kids coming in acutely who might still be on medications and different things. So we did see a little bit of change from admission to discharge, but not statistically significant, whereas the other tests and measures were. And you can see I have a nicer version here, so really see the changes for those of you who like the visual results here. So, and you can see the SCIM, for example, we only had gathered 18, and it's really dependent on the kid's age for that. But 29 kids were reviewed. So you can see the changes from admission to discharge there. With our manual muscle testing, we saw significantly, so you can see here with the stars what are significant with the 3 stars. So lots of changes from admission to discharge, and I have the nice graphs for you too, so you can see the changes here. And what I wanted to point out was you can see that the finger flexion and extension has a much higher score, meaning that the kids have more movement, whereas the shoulder has less, meaning the kids have are not as strong in the shoulder. So we really see that that distal movement is stronger, whereas the proximal movement is weaker. And that is true for the lower extremities as well. When you look at the ankles compared to the hips, you can kind of see that downward trend there. But the good news is we see changes from admission to discharge on all of these. So good changes happening. So with that, I just wanted to present a case study of one of the kids that we have been following since 2016. I think it's important to show kind of changes over time. A lot of times, I know as therapists and medical professionals, we see that these kids come in and they make very slow changes frequently, and so it's sometimes hard to see what progress is being made. So I think this case presentation does a nice job of showing the change over time, and that with continued ABRT, they're continuing to make changes years out from the injury. So Jack came to us in 2016, and he basically came to us and presented with no head control, no upper extremity movement, no lower extremity movement. He was dependent in a tilt and space chair. He was not able to eat by mouth, and his PAM score was a 24. So he was with us for about 12 weeks. He had a lot of medical needs, which is why he was with us for so long. And when he left us after the 12 weeks, he was starting to activate his head movements, but he still needed support at the occiput, so he wasn't able to hold his head on his own yet. And I'll be showing pictures to kind of illustrate these in a second. His upper extremities, he was able to move his digits, so just his fingers in a gravity eliminated plane, but otherwise had no active movement in his arms. His lower extremities, he had gained a little bit more in than his arms, so he had against gravity knee and ankle movements and twitch at the hamstrings and glutes. So again, you see that distal recovery happening before the proximal. He was driving a proportional control power chair with a foot joystick placed on the left foot plate because that's where he had more movement. And that could be a whole nother presentation on how we're doing positioning and chairs for these kids, because it is a little different than what we are seeing with our typical spinal cord injuries. You really have to get creative with that setup. And eating wise, he was doing trials with speech therapy only, but nothing with the family yet. His PAM score had improved from a 24 to a 38. So all good improvements over the 12 weeks. He came back to us in 2017, and he had been getting great home therapy. We had coordinated with his outpatient therapist at home, and they're very receptive and were able to implement the ABRT program at home. I believe he went about 2 or 3 days a week for PCOT and speech. I think his mom was able to carry out some things at home, but again, they had another little kid, and so, you know, life is busy. So I just wanted to kind of like sort of show what he was able to do at the house. His head, he was able to activate kind of the same cervical range of motion with support at the occiput still, but it was stronger and he had more range than he had in 2016. His upper extremities had improved digit strength, and he had emerging twitches on the right hand with digit 1, so I guess he did not have thumb movement in 2016. His lower extremities were getting stronger. He had against gravity at the knee, ankle, and now hamstrings. And the glutes, he had some hip gravity eliminated movement. And he was driving that power chair community level in school, doing really well with it. So he was able to be a typical 4-year-old with that power chair out on the park and everything, as much as the park allowed. And he was now cleared to eat with the family and was tolerating small trials of food by mouth, so was still working on that goal. And his PAM score had improved to a 44. So now just to show some like pictures and videos to kind of demonstrate, oh, sorry, it's really loud. But you can see, I don't know if there's volume. So you can see his head movements here. And now he'll show you his finger movements. Oh, so sorry, I don't think you could really hear me while that was going on, but so his head, he was able to move pretty well, but he still had a very limited range, and that was when he first came to us that first year. And so his mom was able to send me where he was today with that in 2019. I don't know why it's they're all flipped, but he's holding his head for the first time with no support at all. So this is huge, huge progress, and he's even tolerating holding it with some perturbations in his chair. So really good progress there, and that took 3 years for him to progress through to get there. So, you know, with a perseverance, he was finally able to hold that head up, and that's a really big goal to achieve for him. So, and here I have some videos of his fingers progressing. So this first one is going to be from 20. Oh. Okay. So, oh yes. Let's turn the volume down so you guys can hear. So you can see his finger movements. That's what he kind of had when he came back in 2017. So you can see his head movement is a little bit stronger here than before in that first video I showed you, and his finger twitches are stronger, but still the functional grasp isn't quite there. Make sure these volumes are down before I play. And here you can see this is new as of this year. He's starting to actually get flexion and extension in his fingers. Very minimal, but starting to get there rather than just the abduction and adduction. And his thumb is starting to twitch a little bit there. And then this just shows him in a gravity eliminated plane with his arms. This is from his home therapist, so it's hard for me to tell, having not seen him in a year, what's activating there, if it's momentum or if he's actually getting some return proximally, or if his digit movements are what are kind of helping with that too. But showing some good progress, and I just thought that was a good setup for everyone to see with the gravity eliminated or minimized arms. So to show his lower extremity progression here, this first one is him when he was 3 years old with us the first time in 2016. So that's sort of what movement he got back in his legs. You can see he's able to kick here. And then when he came back a year later, just to sort of show you the progression of the strength, he was able to kick against a bolster, which if anyone hasn't kicked against is a lot harder. It gives a lot of resistance. So it's showing his strength improvements there. And then just to show, I don't know if this is going to be sideways, but to show his what his leg movements are doing now. This is not typical locomotor training that the video is showing. This is just showing what movements he's getting back in his legs that he's doing while he's supported in a harness. So just kind of, his mom sent that to me. I thought it showed some nice progression. And I just wanted to show this as a way to get creative. So for him, we needed to keep him motivated. He was in therapy 5 hours a day, so we were lucky enough to have some extra sets of hands, but just being able to do sit to stands and things that he enjoyed doing, and he was very motivated by a mirror that was in front of him. So just kind of getting creative with that. And this shows him starting to drive the power chair with the foot control. Don't judge the setup of the power chair. This is a loaner chair. This is not his. But just showing he's driving with this foot here, and that's a proportional joystick. And he's now driving his chair completely independently all over the place like a crazy man. So that's great. So in summary, AFM is similar to polio in epidemiology, pathophysiology, and presentation, but the presentation can be variable with a wide spectrum of impairments from monoplegia to tetraplegia with the patient on the vent. Recovery is possible, but it can be very slow, and it can be good to take breaks from therapy and let the child just be a kid while doing the home program at home and coming back with continued follow-up with professionals. There's limited knowledge regarding long-term outcomes, but it's important that we know it is important to maximize function and participate in ABRT for the recovery aspect, but also for the secondary health benefits of activity. And there should be very strong coordination with outpatient plans for these kids to prevent chronic complications such as the contractures, the scoliosis, the anxiety, and the decreased community reintegration that we often see. So with that being said, I think we're open for questions unless any of my colleagues have more to add.
I just wanted to mention the fact that we don't know long-term changes, but as a lot of people heard, there is a NIH funded longitudinal study, and that would look at prospectively at all of the children that will be diagnosed with AFM. So we have participated in the design of the data collection tool, and it is very comprehensive, and it will look at every single point that was made during this presentation longitudinally at each one of the children that will be enrolled. So data will be collected. And at the same time, CDC is interviewing?
Yeah, my understanding is that the CDC is also interviewing all of the families of kids that had children affected in 2018. That's what I've heard from the families that we take care of. So they are also looking, this will be a retrospective study of the kids from 2018.
So I think we're done now.
Okay, so thank you, you guys. That was a wonderful presentation, and thank you for agreeing to be our kickoff webinar for the first time that we tried to do this. So I think we had a few technical problems, but not too bad for our first rodeo. We can open it to questions. If you're on the computer, if you go to the bottom of your control panel for GoToMeeting, you can type a question in the chat box and that can pop up. I'm also going to try to unmute folks here. If you are not able to type but would want to give an oral question, you can ask that now. Caller 4, I had kept muted. That's the line we're getting feedback from, so I'm sorry. Caller 4, if you do have access to the computer, you could type your question there, or feel free to email the presenters with your question. So I don't see any questions in the chat box. Is there anybody on an audio line that has a question?
Well, it's either we weren't very interesting or we covered all of the questions during our comprehensive presentation.
I had a question. I was just wondering, just from your own hypothesis, when you started looking at the retrospective data, did you have a hypothesis about how much or in what direction or how these kids were going to change during the intervention? Were your findings in line with what you thought would happen? Were you surprised? I was just curious about that.
So we're all kind of nodding our head. If they were in line with what we've observed without looking at the numbers. I would say probably the thing that surprised us was the incidence of fractures. So that's why we actually went back and looked at numbers. And to tell you the truth, what I took home is that all of the EMGs and nerve conduction studies that were done on the diaphragm, on the phrenic nerve for these children that were ventilator dependent, they were, first of all, they were surface studies, but they were all negative. They all show that the phrenic nerve is dead, doesn't respond, nothing. So we bit the bullet with this one child and went in and said, okay, let's do this direct diaphragmatic stimulation. And lo and behold, she stimulated on one side, not on both, on one side. But you know what? As she grows and when she comes, she's 8 or 9, that one diaphragm is going to give her independent, ventilator-free living. And all of the testing pre and post was negative by our conventional investigations. So what I'm saying is that take that extra step and look for it. Try to find if it through different methods if truly there is any residual function. I don't know if she's breathing over the ventilator because we put a pacer in it and we saved some of her diaphragm, which otherwise would have been atrophied by her being completely dependent and not stimulated, or this was natural recovery. But in her case, it's going to make a difference long term. So.
And are you looking?
Go ahead.
I was just wondering if you were going to look at any more children with a pacer.
Yes, yes, we are obviously. Because we had a little experience with a previous person that a pacer, we didn't put it in, but a pacer was put in longer, about 2 years after, and he didn't do so well. So then we did the 3 weeks, and she did fairly well. So we got a little more aggressive, and we put in the 2 other children that were about 5 months after the injury. So we are collecting all of that data, and we'll see where we're going with it. Kaitlin had something to say about the.
Yeah, I was just going to say, from the outcomes we gathered from the therapy side of things, I think we anticipated or hypothesized that the recovery was happening distal to proximal before that, and it definitely supported that when we gathered that data. But we were surprised that the statistically significant, how much of it was statistically significant changes from admission to discharge, just because I think the recovery was so slow and over the course of the time that we didn't realize how much changes were happening while they were with us. So it was good to see. It supported what we were doing. So definitely surprised. So.
And I also think that we often think that with especially young children with spinal cord injury, you don't see change on the tools like the WeFim and the PAMs and the skim measures. And so we were surprised that you really can see changes on those measures, even in young children. So that was sort of verifying why we collect all this data too.
Yeah, we're data crazy here.
Yeah, well, I thank you for taking the time to present with us today. I know we're at the top of the hour, and we just want to be sensitive to everybody's time. Thank you so much for all your data. I look forward to hearing more information from you guys at the annual meeting, November 5th through 8th in Chicago. And for anybody that hasn't joined us for a quarterly call for the PRNG group, we will meet again on September 12th at 4 p.m. just for a regular business meeting and a discussion of happenings within the group. And so if you are interested in joining us, please feel free to do that. And as I said, this recording will be available for playback through the ACRM Pediatric Rehabilitation Network webpage within ACRM. And with that, I thank everybody and hope to see you all hear you all on our next call or see you in November. Thank you.
Thank you.
Thank you so much.